You know, usually when we talk about a classic historical plague, there's this expectation of something really fast, something furious.
Right, like a wildfire just burning through a dry forest.
Exactly. I mean, you think about the bubonic plague back in 14th century Europe, Yersinia pestis. It was totally devastating. It wiped out, what, a quarter of the population in just a few years?
Easily.
Yeah.
But, as horrifying as that was, it essentially burned itself out.
Because it was just too fast.
Yeah, it was fundamentally self-limiting.
Yeah.
Which is a classic acute infection paradigm. The pathogen killed off the susceptible host so rapidly, and those who actually survived developed such robust immunity that the biological fire simply ran out of fuel.
The human immune system basically recognized the invader and eventually formed a wall on a population level.
Exactly.
But then you step into the world of the human immunodeficiency virus, and suddenly that whole wildfire model is just completely broken.
Oh, completely.
We are looking at a totally different kind of invader here. I mean, HIV doesn't burn out. It's a Trojan horse.
That is the perfect metaphor for it.
And not just any Trojan horse, right? It's one that specifically targets and hides inside the very CD4 positive T cells that are designed to protect the body.
Right. It literally turns the body's primary defenders into these microscopic factories for its own destruction.
Which is just, diabolical.
It is. And that biological reality completely changes the public health response. You can't just wait for the pathogen to run its course. Because HIV is it's a slow-moving lentivirus. It has a decade-long incubation period.
So you're not going to get natural herd immunity.
No, absolutely not. So to combat this, we've had to build this massive, engineered, multi-layered global defense grid.
A defense grid. I like that.
Yeah, we're talking about a defense that spans, complex microscopic biology, deeply ingrained human behavior, and massive global policy shifts.
Which perfectly brings us to our mission for you today. Because if you are reading the Oxford textbook of global public health right now, specifically part 74, you should really consider this your companion audio guide.
Absolutely. We aren't just going to sit here and read you a list of dates and drug names.
Definitely not. Our mission is to build a conceptual map for you. We want to trace exactly how a fatal, acute global emergency was, meticulously engineered into a chronic manageable condition. We are looking at the human story, the public health mystery, and the actual mechanics of how we fight back.
To do that effectively, we really need to establish a core framework right up front. Throughout this whole discussion, I want you to view HIV through a dual lens. You have to look at it simultaneously as an infectious disease and as a chronic disease.
Wait, explain that. Why both?
Well, if you only view it as an infectious disease, like a cold or the flu, the long-term, decades-long management strategies just won't make sense.
Right.
But if you only view it as a chronic disease, say, like diabetes, the transmission dynamics will completely baffle you.
Okay, that makes total sense.
So the framework we're going to use to trace this journey moves through 5 distinct phases. We start with risk, which is the behavioral and structural vulnerability of a population.
Okay, risk. Got it.
Then we move to exposure, the actual viral transmission event. From there, we look at the outcome, the cellular hijack and immune collapse. Then the intervention, which is how we use biomedical tools. And finally, system impact.
System impact, meaning how we strengthen health systems to sustain this defense grid indefinitely, right?
Exactly.
Okay, let's unpack this by zooming out. We are moving from the microscopic Trojan horse to the macroscopic view of the global battlefield. Because to understand how to engineer this massive defense grid, we really have to first map out exactly where the walls are currently failing.
We have to look at the global epidemiology.
Right. And when we look at those global trends, we immediately run into this fascinating public health paradox.
It's a huge paradox.
Yeah.
And it's one that you absolutely must understand if you're going to make any sense of the data. It all comes down to the critical distinction between incidence and prevalence.
Right, because I feel like in normal, everyday conversation, people use those two words completely interchangeably.
All the time. But in epidemiology, confusing them will totally derail your understanding of the HIV epidemic.
Let's set the baseline for everyone listening. Incidence is the rate of new infections in a specific time period. It's new cases. While prevalence is the total number of people currently living with the disease at any given time.
Precisely. Now, here is the paradox. A rise in HIV prevalence in a community or a country can actually be a sign of massive public health success.
Okay, I know we've talked about this, but it still sounds completely counterintuitive. If the total number of sick people is going up, how on earth is that a win?
Let's visualize it. Imagine a bathtub.
Okay, I've got a bathtub in my head.
The water flowing out of the faucet into the tub represents incidence. That's the new infections entering the population.
Got it. Faucet equals incidence.
The water level inside the tub is the prevalence, the total number of people living with HIV. And the drain at the bottom represents mortality, people dying from AIDS-related illnesses and leaving the population.
Okay, I'm with you. Faucet is incidence, water level is prevalence, drain is mortality.
So for the early part of the epidemic, the faucet was wide open, and the drain was wide open.
Oh, wow.
Yeah. People were getting infected, and people were dying very quickly. The water level rose, but it was heavily moderated by the massive death toll. But then we introduced combination antiretroviral therapy, or CART.
And that changes the plumbing.
Radically.
No.
Rolling out CART is essentially plugging the drain. It stops people from dying. They live decades longer. So even if you turn down the faucet, even if incidence drops, the water level, the prevalence, is going to rise significantly simply because people are surviving.
Ah, okay. So the total number of people living with HIV goes up because mortality has plummeted. That is such a clear way to picture it.
Right.
So if prevalence rising can actually mean people are living longer, then declining incidence, turning off the faucet, is the true pure metric of prevention success.
It is the ultimate victory flag.
Yeah.
And we saw this beautifully illustrated in places like Thailand and Uganda back in the 1990s.
Oh, right. The textbook mentions them specifically.
Yeah, in those countries, the incidence, the new infection rate, declined significantly even before antiretroviral therapy was widely available.
Wait, really? Before the drugs?
Yes. That drop was driven strictly by massive behavioral and structural shifts. Things like comprehensive education campaigns and widespread condom distribution, they essentially turned the faucet down before they even had the tools to plug the drain.
That's incredible. Now, when we look at that global map with that understanding, it becomes very clear that there is no such thing as like a single global HIV epidemic.
No, not at all.
It is a collection of vastly different regional microepidemics. The textbook uses the phrase, know your epidemic, and it really is a golden rule.
It's foundational. Let's look at sub-Saharan Africa, for instance. The sheer scale there is staggering. Over a third of all global infections are concentrated in just 10 southern African nations.
It's 10.
Yeah. And the defining characteristic here is that this is a generalized, heterosexually driven epidemic. In the general adult population, prevalence routinely exceeds 10%. And in some specific age and sex groups, it can literally hit 50%.
And the fact that it is generalized means your interventions have to be population-wide. You can't just target one small subgroup.
Exactly. Now, contrast that massive generalized epidemic with Asia and Eastern Europe. These are what we call concentrated epidemics.
Right.
In Eastern Europe and Central Asia, the epidemic is intensely driven by people who inject drugs, or PWID.
So the transmission vector is completely different.
Completely. If you spend all your public health budget on general population condom campaigns there, you will fail. Because if you don't target the injection drug use networks, you will never control the virus in that specific region.
And Asia is even more complex, right?
Oh, very. You have imported cases mixing with indigenous transmission. You have overlapping networks of men who have sex with men, sex work, and injection drug use. It's a very tangled web.
And then, there are these deeply tragic anomalies, like what happened in central China in the 1990s. When you read this in the textbook, it just stops you in your tracks.
It really does.
This was a massive outbreak in rural areas that had absolutely nothing to do with sexual networks or injection drug use. It was driven entirely by illicit, pooled plasma donations.
It is one of the most devastating examples of iatrogenic spread we've ever seen. Spread caused by medical, or in this case, pseudo-medical procedures.
The mechanics of it are horrifying. You had extreme economic desperation in these rural farming villages. People were selling their plasma for cash, and the collectors would draw the whole blood, centrifuge it to separate the plasma, and then, and this is the crazy part, to prevent the donors from becoming anemic so they could donate more frequently, they would pool the red blood cells from multiple donors and reinfuse them back into the individuals.
Which is an absolutely perfect mechanism for massive viral amplification. If just one person in that massive pool of donors was HIV positive, the virus contaminated the entire batch of red blood cells.
So when those cells were reinfused,
The virus simply swept through whole villages simultaneously. Entire generations of adults were wiped out in localized areas, leaving behind thousands of orphans. It was a structural and regulatory failure, not a behavioral one.
God, that's just heartbreaking. And then when we shift over to the Americas, The geography of the epidemic continues to morph based on those structural factors.
Yes, it shifts again.
You have these air bridges connecting the PWID epidemic in Puerto Rico directly to major U.S. cities like New York or Philadelphia, facilitating rapid viral transit back and forth.
And you have completely divergent policy approaches across the Americas, too. For example, the text notes Cuba's approach in the 1980s.
Oh, the quarantine approach?
Yes, they utilized a mass screening and quarantine approach. They were literally segregating HIV-infected individuals into their own state-run sanitariums.
Which is wildly controversial.
Highly controversial. From a purely epidemiological standpoint, the Cuban quarantine approach heavily suppressed initial incidents by forcibly removing the source of the exposure from the general population. But obviously it raises intense questions about human rights and the social cost of such draconian public health measures.
Which brings up a huge question for you listening to this. If the epidemic looks so completely different in sub-Saharan Africa, Eastern Europe, rural China, and the Americas, is mapping the global HIV epidemic essentially like tracking entirely different weather systems? Like a hurricane in one region requires a totally different emergency response than a drought in another.
What's fascinating here is that your weather analogy perfectly highlights the difference between hazard and risk. This is a core public health concept.
Okay, break that down for us. Hazard versus risk.
The virus itself, the HIV lentivirus, is the hazard. It is identical everywhere. It's the exact same biological entity, whether it's in a plasma pool in China or a sexual network in South Africa. But the human behavioral and structural context, the weather system, if you will, creates the actual risk.
So the hazard is the storm. The risk is whether you live in a floodplain or a reinforced bunker.
Exactly.
Right.
A hurricane requires sandbags and evacuations. A drought requires irrigation and water rationing. An epidemic driven by injection drug use requires clean needle exchanges and methadone. A generalized heterosexual epidemic requires massive population-level testing and biomedical prevention.
You cannot apply the drought solution to the hurricane.
Precisely. The hazard is universal, but the risk is highly localized.
Okay, so to understand why these localized microepidemics are so incredibly difficult to extinguish, why we can't just put up one generic type of sandbag and be done with it, we need to zoom all the way back in. We need to look at the cellular siege.
Back to the microscopic level.
Right. Because the ultimate question remains, why didn't this virus just burn out? What makes this biological hazard so resilient?
That brings us to the unique biological mechanism of the lentivirus life cycle. The prefix lenti actually means slow.
Slow virus.
Right. HIV is a retrovirus, which means its genetic material is encoded in single-stranded RNA, not double-stranded DNA like human cells. So to successfully hijack a human T cell, it has to convert its RNA backwards into DNA.
Hence the term retrovirus. It's moving backward against the normal flow of genetic information.
Correct. And to do this, it brings along its own highly specialized enzyme called reverse transcriptase.
It packs its own tools.
It does. Once it converts its RNA into DNA, another viral enzyme called integrase grabs that newly minted viral DNA, carries it into the nucleus of the human cell, and permanently splices it into the host's own genome.
It literally becomes part of you. The cell's own instruction manual has been rewritten to include the blueprints for the virus.
Yes, and that integration is exactly why it doesn't burn out quickly. Once it's integrated, it can establish a latent reservoir.
A latent reservoir. What does that mean practically?
It means the viral DNA can sit quietly inside long-living memory T cells for years, completely invisible to the immune system and completely untouchable by drugs, because it isn't actively replicating.
Oh.
This integration explains the long, silent incubation period. An individual can carry the virus and unknowingly transmit it to others for a decade before their immune system collapses enough for them to feel severely ill.
Here's where it gets really interesting, though. Let's talk about how the virus actually gets into the cell in the first place. Because the docking sequence is like something out of a sci-fi movie. Or like a microscopic bank heist.
It is an incredibly sophisticated process.
It is incredibly specific. The virus is encased in a lipid envelope, and protruding from this envelope are these protein spikes. The tip of the spike is a glycoprotein called GP120.
And just for context, GP stands for glycoprotein, and 120 is its molecular weight.
Right, so this GP120 protein is like a highly specialized key that binds perfectly to the CD4 receptor on the surface of the human T helper lymphocyte.
But binding to CD4 is just step one. It's like swiping a key card at the front door. It gets you to the lobby, but not into the vault.
I love that.
When GP120 binds to CD4, the viral protein undergoes a dramatic conformational shift. It physically changes its 3D shape.
It transforms.
Yes. This shape change exposes a new binding site that allows it to lock onto a second receptor on the cell surface, which we call a co-receptor. The two primary co-receptors that HIV uses are called CCR5 and CXCR4.
And once it grabs that co-receptor, it's game over for the cell. The conformation shifts again, and a second viral protein, GP41, which is basically the stalk of the spike, springs into action.
A harpoon.
Yes, it literally harpoons the cell membrane, pulls the virus and the cell tightly together, and fuses them. The viral core empties into the cytoplasm. The Trojan horse is inside the gates.
And once inside, the reverse transcription we mentioned earlier begins. But we need to add a crucial layer of complexity to that reverse transcriptase enzyme. It is notoriously error-prone.
Wait, error-prone, like it makes mistakes.
Constantly. Unlike human DNA replication enzymes, which have sophisticated proofreading mechanisms to fix typos, reverse transcriptase has no backspace key. It just barrels forward, making constant transcription errors.
So every time it copies its RNA into DNA, it's introducing mutations.
Exactly. This leads to an extreme viral mutation rate. Within a single untreated patient, billions of new virions are produced every day, and a massive percentage of them have slight genetic variations.
Which is an absolute nightmare for developing a vaccine, because
Yeah.
you're trying to build an antibody against a target that changes its shape every single day.
Precisely. If we trace the viral evolution and phylogenetics backward using these mutations, the origin points back to Central Africa in the 1920s or 1930s.
Through a zoonotic spillover, right?
Yes. The precursor virus, SIV or simian immunodeficiency virus, jumped from chimpanzees to humans, likely via exposure to infected blood during bushmeat hunting. Because of that high mutation rate over the last century, the virus has splintered into multiple major groups, subtypes, or clades.
Glades.
Right. And when two different clades infect the same person, say someone gets exposed to clade B and clade C, those viruses can actually swap genetic material inside the cell and recombine into what we call circulating recombinant forms, or CRFs.
It's like viral modularity. They're just building new versions of themselves.
Exactly.
But public health officials aren't just helplessly watching these mutations happen. They actually use them. The textbook talks about how they use what are called molecular clocks.
Yes, this is brilliant. By analyzing the sequence evolution rates, meaning looking at how fast the virus is mutating and how the genetic sequences are diverging from one another, epidemiologists can actually mathematically model sexual transmission networks.
It's an incredible application of molecular biology. If you look at the viral RNA sequence of person A and person B, and they are 99% identical, you can infer a recent direct transmission pathway.
Right. But if they're 80% identical, there are likely many intermediate hosts or years of evolutionary time between them.
It allows us to see the invisible pathways of the epidemic. It turns epidemiology into a highly advanced form of molecular detective work.
It really does.
But understanding the biology doesn't just help us track the virus, it tells us exactly where to strike back. One scientist mapped out how the Trojan horse stalks using GP120 and CCR5, how it reverse transcribes its RNA, how it integrates into our DNA, and how it gets chopped up by protease to form new viruses. They realized they had a map of vulnerabilities.
A blueprint for the defense grid.
Exactly. They could engineer specific barricades to block the virus at every single step of that life cycle.
And that transition from biological understanding to pharmacological intervention represents one of the greatest scientific triumphs in human history. I mean, we moved from diagnosing a universal death sentence to engineering a highly targeted defense.
So let's talk about that defense. The development of antiretroviral therapy. To appreciate where we are now, we have to start with the first weapon we had, which was AZT, or zidovudine.
AZT belongs to the very first class of HIV drugs called nucleoside reverse transcriptase inhibitors, or NRTIs. The mechanism of AZT is elegant in its simplicity. Remember that reverse transcriptase enzyme is trying to build a new DNA chain based on the viral RNA template. AZT is essentially a molecular decoy. It is a fake DNA building block that chemically mimics the real nucleotide thymine.
I always think of it like a bricklayer building a wall. The enzyme is the bricklayer. AZT is a brick that looks totally normal from the bottom, so the bricklayer grabs it and slaps it onto the wall. But the top of the AZT brick has no mortar. It completely lacks the specific chemical hook, the 3' hydroxyl group, needed to attach the next brick.
It's a perfect analogy. Once that AZT molecule is incorporated, chain elongation terminates. The copying process simply stops. The viral DNA is incomplete, so it can't integrate into the host nucleus, and the infection of that specific cell is halted.
And there's a big but here, AZT was initially used as a monotherapy, just that one single drug. And while it seemed like a miracle at first, patients' CD4 counts went up, they felt better, it ultimately failed spectacularly.
And it failed exactly because of the biology we just discussed. The relentless viral mutation rate. With billions of virions replicating and a reverse transcriptase making constant errors, it was only a matter of time before a random mutation changed the shape of the reverse transcriptase enzyme, just enough that it could distinguish between the real thymine building block and the fake AZT brick.
It learned to reject the brick without mortar.
Exactly. Under the intense selective pressure of just a single drug, any virus with that specific mutation survived, while all the wild-type viruses died off. Within months, that resistant strain multiplied and became the dominant virus in the patient's body. Monotherapy was functionally useless.
So the science had to evolve, leading to combination antiretroviral therapy, or CART, in the mid-1990s. We realized we couldn't just throw one rock at a time. We had to hit the virus with a highly coordinated multi-class arsenal. We basically threw 3 different wrenches into 3 different parts of the machine simultaneously, mathematically ensuring the virus couldn't randomly mutate fast enough to dodge all 3 at once. Let's walk you through this incredible arsenal. We mentioned NRTIs, the fake building blocks. What else do we have?
We have non-nucleoside reverse transcriptase inhibitors, or NNRTIs.
How are those different?
Instead of acting as a fake building block, these drugs bind directly to a specific pocket on the reverse transcriptase enzyme itself. They physically jam the machinery and distort its shape so it can't function.
So if NRTI is a fake brick, NNRTI is tying the bricklayer's hands behind his back.
Precisely. Then we have protease inhibitors, or PIs. This targets the very end of the viral life cycle. After the virus has hijacked the cell and produced all the raw, long protein chains needed to make new virions, an enzyme called protease has to cleave these chains into their smaller functional pieces.
It acts like scissors.
Yes. Protease inhibitors block those molecular scissors. The virus still buds out of the human cell, but because the proteins aren't cut correctly, it remains immature and completely non-infectious.
That's amazing. And then over the last decade or two, we've developed even more sophisticated weapons. Integrase inhibitors, which block the virus from inserting its DNA into the host genome. So even if reverse transcriptase finishes its job, the DNA just sits there uselessly in the cytoplasm until it degrades.
Right.
And we even have entry inhibitors like CCR5 antagonists, which block that specific co-receptor on the outside of the cell, preventing the Trojan horse from even harpooning the membrane in the first place.
Exactly. And to maximize the impact of these drugs, clinicians often use a strategy called pharmacological boosting.
Boosting? How does that work?
Well, for example, protease inhibitor is incredibly effective, but it is rapidly broken down by the patient's liver. So it is often co-formulated with a low dose of another drug called ritonavir.
Oh, I've heard of that.
Yeah. Ritonavir isn't there to fight the virus itself. It's there to inhibit the specific liver enzyme, CYP3A4, that breaks down the primary protease inhibitor. This artificially boosts the levels of the primary drug in the bloodstream, ensuring it stays at therapeutic levels much longer, which allows for much simpler, once-daily dosing.
So we have these incredible, almost miraculous biochemical weapons. But the textbook brings up a massive public health tension regarding when to actually deploy them. The clinical reasoning and the thresholds for starting treatment are heavily dictated by geography, health system infrastructure, and, frankly, pure economics.
This is a harsh reality of global health. In resource-rich settings like Western Europe or the U.S., the clinical guideline has universally shifted to test and treat. The moment a patient tests positive, regardless of how healthy their immune system is, you start them on CART immediately.
But in low and middle income countries, LMICs, the text outlines a much starker reality. Because of severe resource constraints like not having enough drugs or enough lab capacity to monitor patients, national programs have historically had to wait until the patient's immune system is visibly failing.
They have to wait until the CD4 count drops below 500, or in some older guidelines, below 350 cells per microliter before initiating therapy. Keep in mind, normal is above 500 to 1500.
It is the devastating reality of rationing care. From a purely biological standpoint, we know that earlier treatment preserves the immune system architecture better and prevents opportunistic infections. But when a national health budget can only afford a limited amount of antiretrovirals, policymakers are forced to triage. They treat the sickest patients first to prevent imminent mortality.
It's an agonizing public health decision.
I have to play devil's advocate here for the patient experience, though. In public health, we talk about CART like it's a magic wand. Take these pills and you'll live. But we're talking about a lifelong daily regimen of highly potent chemicals. The text mentions severe toxicities. Older NRTIs can cause lactic acidosis, where dangerous levels of acid build up in the bloodstream.
Yes. Yeah.
Protease inhibitors can cause lipodystrophy, an abnormal redistribution of body fat where patients lose fat in their face and limbs but accumulate it in the abdomen or back of the neck. What happens when you take those physical side effects and you drop them into a setting where a patient is dealing with severe poverty and food insecurity?
It's a critical point that too many public health models ignore. You simply cannot view the medication in a vacuum separate from the patient's lived environment. Imagine a patient starting CART. As their viral load drops and their immune system recovers, they often experience an intense, surging return of their appetite.
Because they're finally getting healthy.
Right. But if they live in an environment with severe food insecurity, they have no food to satisfy that hunger. Taking the medication on an empty stomach can exacerbate nausea and intense pain.
So what do?
They do what any human being in acute distress would do. They stop taking the pills. And when adherence drops, the drug levels in the blood fall below the therapeutic threshold. The virus begins replicating again, but now it's replicating in the presence of a low dose of the drug.
Which is the exact recipe for breeding drug resistance.
Exactly. This is why the Oxford text emphasizes that a purely biomedical response is incomplete. Providing pills without addressing community development, nutrition, and socioeconomic support is a failing strategy.
Which perfectly transitions us into the next conceptual phase, because if we can achieve adherence and we have drugs that suppress the virus to undetectable levels in the individual, how do we scale that up? How do we take a clinical treatment for one person's outcome and turn it into a population-level shield to prevent exposure for everyone else?
This represents perhaps the most profound paradigm shift in modern HIV public health. The concept of treatment as prevention, or TASPP.
TASPP.
Right. For the first 2 decades of the epidemic, treatment and prevention were totally siloed. Treatment pills, clinics, doctors was for the sick. Prevention condoms, billboards, education was for the healthy.
But a monumental clinical trial completely shattered that wall between treatment and prevention. The HPTN 052 trial. I love talking about this study because the numbers are just jaw-dropping.
They really are.
They looked at thousands of serodiscordant couples, meaning couples where one partner is HIV positive and the other is HIV negative.
They randomized these couples into 2 groups. In one group, the HIV positive partner started antiretroviral therapy immediately. In the other group, they waited until the positive partner's CD4 count dropped, which, as we discussed, was the standard of care at the time. The researchers wanted to see if early treatment not only kept the infected partner healthy, but also prevented them from passing the virus to their negative partner.
And the results were so overwhelmingly conclusive, they actually had to stop the trial early. They found that if you treat the infected individual early and their viral load is fully suppressed by CART, it reduces the sexual transmission of the virus to their uninfected partner by a staggering 96%.
96%.
Well,
In the realm of public health interventions, achieving a 96% efficacy rate is almost unheard of. It fundamentally blurred the line between clinical care and public health prevention. It proved that treating the individual is protecting the community.
it's incredible.
This is exactly what gave birth to the global campaign of U equals U. Undetectable equals untransmittable.
But to utilize treatment as prevention, to get people undetectable, you first have to find the people who are infected. And you can't just wait for them to show up at the hospital sick. This requires a critical differentiation in public health terminology that the text stresses, the difference between surveillance and screening.
It's an essential distinction. AIDS, acquired immunodeficiency syndrome, is a surveillance case definition. It is a lagging indicator.
A lagging indicator.
Yes. Epidemiologists use the AIDS definition to track advanced disease. They are mapping out where the health system has failed people so badly that their immune systems have completely collapsed, and they are presenting with severe opportunistic infections like Kaposi's sarcoma or pneumocystis pneumonia. Tracking AIDS tells you where the fire has already burned down the house.
Conversely, routine opt-out HIV testing in clinics and communities is a screening tool. It is an active, forward-looking intervention. The goal of screening is to find asymptomatic individuals, people who feel perfectly healthy and have no idea they carry the virus.
Exactly. Once we find them, we can initiate CART immediately, suppress their viral load, and break the chain of transmission before they ever pass it on. Surveillance watches the fire. Screening takes away the fuel.
And treatment as prevention is just one pillar of the modern biomedical prevention portfolio. The textbook outlines a robust, multi-layered shield. For those who are HIV negative but at high risk of exposure, we now have pre-exposure prophylaxis, or PrEP.
This involves an HIV-negative person taking a daily pill containing two antiretroviral drugs. If they are exposed to the virus, the drugs are already in their bloodstream, ready to block reverse transcription before the virus can establish a latent reservoir.
And then there's voluntary medical male circumcision, or VMMC.
Yes, and we must note that VMMC is not just observational. It is supported by 3 definitive, massive, randomized controlled trials conducted in Africa. They demonstrated that adult male circumcision provides an approximately 60% reduction in the risk of female-to-male sexual transmission.
60% is huge.
It is. In regions with generalized heterosexual epidemics, rolling out VMMC provides a highly significant lifelong reduction in population-level incidence.
We also have the near elimination of mother-to-child transmission, or MTCT, in high-income settings. Without intervention, a mother living with HIV has a 15% to 45% chance of passing the virus to her baby during pregnancy, labor, delivery, or breastfeeding.
But by providing CART to the pregnant mother to suppress her viral load, modifying delivery methods if necessary, and providing formula alternatives to breastfeeding, that transmission rate drops to below 1%. If we connect this to the bigger picture, though, we have to acknowledge a sobering reality. Biomedical tools are essentially inert objects. A pill does absolutely nothing if it stays in the bottle. A condom is useless in the wrapper. Biological tools only work if behavioral adherence and social structures support them.
Right.
For decades, prevention was simplified into the ABC campaign. Abstinence, be faithful, use condoms. But the consensus now is that ABC alone is wildly insufficient. It places the entire burden of prevention on individual willpower, completely ignoring the structural context of people's lives. We must move to structurally supported combination prevention.
And that leads us to the darkest but perhaps most critical part of this deep dive. We have the medical armory to stop the virus. We have PrEP, we have CART, we have U equals U. So why, as you read this textbook, are there still millions of new infections happening globally every single year? Are actively, measurably sabotaging the defense grid.
Yes, they are the saboteurs.
Now, just to be incredibly clear to you listening, we are going to examine historical and political policies mentioned in the Oxford text that have influenced the epidemic. We are not endorsing any political viewpoint here, left-wing or right-wing. We are strictly analyzing the epidemiological impact of these policies as documented in the source text.
Exactly. When epidemiologists analyze policy, they don't look at it through a political lens. They look at it through the lens of transmission dynamics.
Yeah.
Bad policy acts as a massive epidemiological driver. It is a quantifiable hazard.
Let's look at the data the textbook highlights regarding this. They point to a striking mathematical model by researchers Lurie and Drucker regarding the United States. Between 1987 and 1995, there was a U.S. ban on using federal funding for needle and syringe exchange programs.
To give context, needle exchange programs provide sterile injecting equipment to people who inject drugs. The data from around the world clearly show that providing clean needles drastically prevented the transmission of HIV through shared blood, and crucially, it did not increase the rates of drug use. It simply made the existing drug use biologically safer.
But the policy banned federal funding for it anyway. So Lurie and Drucker actually ran the numbers to quantify the cost of that specific policy gap. They estimated that this single funding ban resulted in between 4,394 to 9,666 excess, entirely preventable HIV infections.
It's astounding.
And beyond the human tragedy, those thousands of lifetime infections cost the healthcare system hundreds of millions of dollars in eventual treatment. The policy itself essentially became a vector for the disease.
The text points to international examples as well, which are just as stark. It discusses Russia's continuing ban on opiate substitution therapy, specifically methadone. Methadone allows individuals addicted to injectable heroin to transition to a safe, orally administered medication. It entirely removes the needle and the risk of HIV transmission from the equation.
But it's banned there.
Yes. By legally refusing to allow this proven medical intervention, the policy actively fuels the intense, PWID-driven HIV epidemic raging across Eastern Europe and Central Asia.
The text also covers the historical period of the Mbeki administration in South Africa in the early 2000s. The administration heavily questioned the causal link between HIV and AIDS and tragically delayed the massive systemic rollout of antiretroviral therapy.
That policy delay allowed the generalized epidemic in South Africa to surge unchecked for a critical period, resulting in hundreds of thousands of preventable deaths and millions of new infections.
And beyond top-down government policy, there is the insidious daily sabotage of intersectional stigma. In public health, we use a framework called the cascade of care. It outlines the sequential steps a patient must take. You have to get tested, receive your results, get linked to a clinical care provider, receive a prescription, adhere to the daily pills, and finally achieve viral suppression.
Every single step is a potential drop-off point where a patient is lost to the system.
And stigma creates massive drop-offs. We are talking about intersectional stigma. The compounding, overlapping effects of homophobia, the criminalization of sex work, extreme poverty, and the intense societal shame associated with the virus itself. This stigma keeps vulnerable populations completely out of the test and treat pipeline.
Consider the behavioral reality. If a young man who has sex with men lives in a country where his existence is quite literally criminalized by the state, he is not going to walk into a government-run health clinic, hand over his ID, and request an HIV test.
Of course not.
The immediate fear of arrest, blackmail, or profound social ostracization from his family is a much greater, more acute hazard to his daily survival than a slow-moving lentivirus.
So what does this all mean for the defense grid? It means you fundamentally cannot medicate your way out of an epidemic if the marginalized groups who need the medication most are legally or socially terrified to walk through the clinic doors. A pill cannot cure a human rights abuse.
Exactly. Which means to actually utilize our biomedical armory, we have to entirely rebuild the physical and operational systems that deliver it. We have to design systems that bypass the stigma.
Which brings us to our final core framework phase, system impact, rebuilding the fortress. To counter that structural stigma and to efficiently deliver chronic, lifelong care to millions of people, the actual physical health systems must be re-engineered. And the Oxford text provides the ultimate real-world case study for this, YRG Care in Chennai, India.
The story of YRG Care is deeply inspiring. It was founded by Dr. Suniti Solomon and her team. Dr. Solomon is actually the researcher who, along with her colleagues, documented the very first cases of HIV in India back in 1986 among female sex workers in Chennai.
And at the time, the stigma was suffocating. People thought it was a Western disease. Patients were being turned away from hospitals. Doctors were terrified to treat them. But rather than just publishing her epidemiological paper and walking away, Dr. Solomon built a fortress. YRG Care became the blueprint for taking a holistic, non-judgmental approach to infectious disease management.
They didn't just open a dispensary to hand out pills, they built a comprehensive care network from the ground up. They integrated voluntary counseling and testing, or VCT, providing a safe, strictly confidential space for people to learn their status. They implemented harm reduction strategies.
They even built labs, right?
Yes, they built internationally accredited state-of-the-art laboratories to monitor CD4 counts and viral loads, which was revolutionary for an NGO at the time.
But the part that really highlights the system aspect is how they integrated social support. They recognized the extreme cultural stigma in India around marriage and childbearing if you were HIV positive. It was a social death sentence. So YRG Care actually provided matrimonial services for people living with HIV, helping them find partners who shared their status, allowing them to build families safely with the help of MTCT prevention.
They offered nutritional counseling and primary care. They recognized that the patient is a complex whole person, not just a biological host for a virus.
This completes our framework. This is the definition of system impact. The textbook outlines, specifically in Table 8.13.4, the essential elements required to transition an emergency, panic-driven HIV program into a sustainable, long-term local health system. And there are some incredibly smart logistical mechanics here that listeners need to grasp, things like task shifting.
Right.
Walk us through task shifting because it's brilliant in its pragmatism.
In regions with a massive shortage of fully licensed physicians, you simply cannot rely on doctors to do everything. It creates an impossible bottleneck. Task shifting involves breaking down clinical care into specific duties and extensively training nurses, clinical officers, and community health workers to perform them safely.
So delegating to increase capacity.
Exactly. A community health worker can monitor medication adherence. A nurse can initiate routine cart refills. It vastly expands the physical capacity of the health system to manage millions of chronic patients.
The text also highlights the unglamorous but critical world of pharmacy logistics. You have to totally re-engineer national supply chains to prevent stockouts.
Oh.
Because if a rural clinic runs out of antiretrovirals for even 2 weeks, the virus inside those patients begins replicating, drug resistance builds across the cohort, and the entire community is put at risk of a resistant strain outbreak.
They also utilize hub-and-spoke models of care. You don't make every patient travel to the massive tertiary hospital in the capital city, the hub. You push the routine, daily HIV care deep into the rural primary care clinics, the spokes, while keeping the complex failing cases at the hub. It decentralizes the defense grid.
But building this grid and maintaining the supply chains, the labs, the community workers, it takes money. Billions of dollars.
This raises an important question, one that looms over the entire field of global public health today. How do we maintain funding and avoid what policymakers term HIV fatigue?
Right, because HIV isn't the new terrifying headline anymore. It's a chronic managed background issue for the general public in high-income countries.
Exactly. The economic payoff of prevention is incredibly clear. Every single infection prevented today saves hundreds of thousands of dollars in lifetime medical costs and keeps an adult economically productive. Yet, global health budgets face immense, constant constraints and competing priorities. Maintaining the global defense grid requires a sustained political will that must vastly outlast the initial panic of the 1980s emergency.
That is the ultimate challenge. We have the tools. Do we have the stamina? Okay, we have covered massive ground today. We've gone from the molecular machinery of the lentivirus reverse transcriptase all the way up to global human rights policy and supply chain logistics. To make sure these frameworks are solidly locked into your memory, before we close out, we are going to do a rapid mental check. I'll read 5 single best answer prompts based on the core public health principles we've unpacked. I'll pause for just a moment so you can lock in your answer, and then the expert will break it down and tell you exactly where to look in the chapter. Ready? Here we go. Prompt 1. Which epidemiological metric is most indicative of true prevention success, but can confusingly appear to worsen as CART rolls out in a population?
The answer is incidence versus prevalence. Remember the bathtub. As people survive longer on CART, the prevalence, the total number of cases, rises. But true prevention is measured by declining incidence, the rate of new infections. If you want to review this paradox, revisit the Global HIV Trends section of the chapter.
Prompt 2. What are the 2 primary host cell co-receptors required for the HIV Trojan horse to successfully fuse with the T-cell membrane?
The answer is CCR5 and CXCR4. Remember, the viral GP120 protein binds to the CD4 receptor first, but it must undergo a shape change and grab one of those specific co-receptors to trigger the GP41 harpoon fusion. To consolidate this molecular docking sequence, revisit the section on viral entry and replication.
Prompt 3. In strict public health terminology, what is the primary difference between AIDS and HIV disease?
AIDS is a surveillance case definition used by epidemiologists to indicate severe immunologic suppression. It is a lagging indicator of health system failure. HIV disease, however, is a clinical spectrum that spans all the way from acute infection to decades of chronic managed care. You can review this distinction under current status of the epidemic.
Prompt 4. What was the revolutionary public health finding of the HPTN 052 clinical trial?
The answer is treatment as prevention, or TASP. The trial proved that early initiation of CART, which fully suppresses the viral load, reduced sexual transmission to an uninfected partner by 96%. It proved that individual clinical treatment acts as population-level prevention. Revisit the Elements of Combination Prevention section for the details.
Prompt 5. When dealing with localized microepidemics, what specific intervention provides the highest yield for an epidemic primarily driven by PWID?
The answer is harm reduction, specifically clean needle and syringe exchange programs and opiate substitution therapy like methadone. You must address the specific risk pathway of the population, not just the general hazard. This is heavily covered in the Packages of Tools for Combination Prevention section.
Excellent. If you grasped those concepts, you have the structural blueprint to completely dominate this chapter.
Before we sign off, I want to leave you with one final provocative thought to mull over as you close your textbook today. For decades, billions of dollars have been spent searching for a biological cure in the laboratory, a microscopic way to excise that integrated viral DNA from the latent reservoirs in our cells. But given the reality of the HPTN 052 trial, we already possess the biomedical tools to suppress the virus to completely untransmittable levels. Perhaps the actual cure for the pandemic isn't biological at all. Perhaps it's sociological. If we could achieve perfect equity in global healthcare access, eradicate intersectional stigma, and provide combination antiretroviral therapy to every single human being who needs it, does the virus simply run out of host and quietly disappear from the human story?
Now that is a deep dive. Here are the details of this episode.
Hive AIDS, byline, epidemiology, prevention, treatment, and the global transformation of a once fatal epidemic. Episode description. Hive AIDS has shaped modern public health more profoundly than almost any other infectious disease. Since its emergence in the late 20th century, it has caused millions of deaths, reshaped global health governance, and driven innovation in prevention, treatment, and human rights advocacy. This episode examines global epidemiology and regional variation. This episode examines modes of transmission in key populations. This episode examines antiretroviral therapy, ARTAC, and treatment as prevention. This episode examines pre-exposure prophylaxis, ProPT, and biomedical prevention. This episode examines mother-to-child transmission prevention. This episode examines health system strengthening through HIV programs. This episode examines funding mechanisms and global partnerships. This episode examines the goal of epidemic control and elimination. This episode examines HIV illustrates the intersection of biology, behavior, inequality, and political response. The advent of effective antiretroviral therapy transformed HIV from a fatal diagnosis into a chronic manageable condition. Yet disparities in access persist, particularly in sub-Saharan Africa and among marginalized populations. This episode examines. The episode highlights how sustained investment, community mobilization, and evidence-based policy have reduced incidence and mortality in many settings while emphasizing the need for continued vigilance and equity. This episode examines. HIV is both a scientific and social story, one of resilience, advocacy, and systemic response. This episode examines. This episode examines. Key takeaways. This episode examines. HIV/AIDS remains a significant global health issue. This episode examines. Antiretroviral therapy dramatically reduces mortality and transmission. This episode examines. PrEP and prevention of mother-to-child transmission are highly effective. This episode examines. Stigma and legal barriers impede progress. This episode examines. The global funding partnerships have shaped HIV response. This episode examines. Epidemic control requires sustained investment. This episode examines. Equity remains central to elimination efforts.